So what is the process like to clinically diagnose a man with prostate cancer, right? It used to be that, well, you have a high PSA, sir, you need a biopsy. Boom, that's it, end of story. Of course, that led to unnecessary biopsies, unnecessary treatments of prostate cancer, and so forth. That was a problem. Though many people's lives were saved, others were just undergoing these biopsies and its consequences and side effects and kind of had to deal with it. Now there's different ways. There's urine tests and other mechanisms to determine, along with PSA, still useful, to determine if one needs a biopsy. Today's conversation is with Dr. David Albala. Dr. David Albala is Chief of Urology at Crouse Hospital and member of the Associated Medical Professionals in Syracuse, New York. He is considered an eminent international authority in laparoscopic and robotic urological surgery, and much of that is because he was trained at Washington University with Ralph Klayman, who is probably considered one of the Mount Rushmore of laparoscopic urology, I would say. My conversation with David was less about surgery, was a little bit about his life and surgery, and it's very interesting at a personal level for sure, but more so on a clinical level. What is his process? I'm always want to know what's the right process to for a patient to prevent a biopsy, right? Because you heard me say this many, many times over and over again. No man wakes up in the morning and says, wow, I can't wait to get a biopsy today. I've never heard that, right? So what is his process? And what tools does he use? What samples does he use to determine, yep, you know what, in this case, sir, you need a biopsy. So enjoy today's conversation with an amazing luminary person, clinical person, really clinical, really loves his patients, amazing, good-hearted person, good-hearted doctor, the one and only Dr. David Albala. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. And now, I'd like to acknowledge our three amazing sponsors that you will hear about throughout this podcast. One is XY Wellness, a company I'm very familiar with as co-founder and medical director, a lifestyle company, XY Wellness, specific for men with prostate cancer. Next is Veracyte, the makers of Decipher genomic test. After a biopsy or even a prostatectomy, you want to know how your cancer may behave. This is how the genomic test Decipher can help. Third, ExoDx. Prior to having a biopsy, you want to know if you really need one. And the ExoDx test, a urine test, is very helpful to determine if you need a biopsy or if you don't. Thank you to today's sponsors. Welcome to the Dr. Gio podcast. I am your host, Dr. Gio, where it is my intention and my purpose to help you optimize your prostate health, including prostate cancer, of course, testosterone, erections, and how can we as men live optimally and better with better health with age. Today, my conversation is with Dr. David Albala, which some about because we spoke about in the intro of this podcast episode. David, thank you so much for being on. I can't tell you what a pleasure it is. We were talking right before we started recording how the beauty of this podcast thing that I started about 2 years ago is that I get to talk to people like you, which probably it wouldn't happen in any other circumstance. For no other reason is that we all have busy lives. So thank you for being on.
Listen, it's a real pleasure, and it's a great service that you're doing. You know, social media has changed. When I did my training, obviously this wasn't around, but this is
Were there beepers around when you did your training? I'm not aging you or saying, but I'm wondering because beepers were not that long ago. So were there beepers? Is that how you got paged?
We had beepers, and the first cell phone was so big, a real chore to carry around in the
Right.
hospital. But
Right.
things have changed, and I think much better. And this is a great opportunity to get out to a large audience to talk about these are important topics. And men as we age, start to worry about these things, and we worry about how healthy we're going to be. We worry about death. We think about it more. I mean, I never thought about death, when I was younger. I see all these men come in and they're worried about, what extend my lifestyle and my quality of life. And it's a real pleasure here. And we've met a couple times prior to this, and it's I've just heard things, and I just want to congratulate you for all the hard work and the time that you put in, because this is something that's a great service to people.
David, I thank you so much, and that means a lot to me. Look, I think that it's a matter, we talk a lot about shared decision making. That's the new thing these days, and it's great, right?
Mm-hmm.
But how can there be shared decision making if the patient doesn't really know enough information to be involved in that decision? So my goal with my platforms is to educate at an optimal level, so when they go see you or anyone, they can have enough knowledge, foundational knowledge, to be part of that conversation. Do I need a biopsy? Shouldn't I may not need it. Dr. Albala, what do you think? Or I do, etc. So I've been honestly blessed to have this platform and have so many people listen to the podcast, so thanks for that.
I think it's great, and I think these decisions. It's interesting being the physician on one side of the table. When you become a patient, and listen, I haven't had prostate cancer, but I've had kidney stones. Being treated for kidney stones, I think actually has made me a better physician, because, I used to think, well, when we take a stent out, it's just putting a scope in. You don't realize what it's like until you have it done to yourself. And I've never had a biopsy. I've done plenty of biopsies, made decisions about whether doing biopsies for prostate cancer. But I think it's that physicians understand positions that patients are in, that they're relying on you, give them information. And that's the beauty of medicine. I mean, in ways we're teachers, and we're trying to
100%.
teach and educate the population about their disease state. Granted, we've gone to medical school and we understand the disease process and the science a little more, but it's important to understand the anxiety that patients have, understand their level of education. Sometimes you can talk at a very high level, and sometimes you need to be at a lower level. And I think what makes a good physician is, obviously, you got to be caring and sensitive and understanding. Think of it if you were on the other side of the table, and every patient that can my thought process when they come in. If I were sitting there, what would I want my physician to tell me? And that's how I've lived my life. I've had a blessed career, 21 years in academics at Loyola in Chicago, and then down at Duke, and, in upstate New York, great run of taking care of patients. And I couldn't think of anything better to do than what I'm doing right now.
Well, that makes me happy and sad a little, because the way you're talking sounds like maybe you have 5, 10 more years of working the way you sound, and not more than that. I think more patients need physicians like you. So I hope you hang on with your health now. And I know you're doing a lot of health things. We spoke about that earlier. So I hope that
I
prompts you
plan to
to
be
hang in
to
there
be
a little
around
bit
many
longer.
more years.
Don't
I
cut
think
yourself. Don't cut yourself short, David.
I'll,
You spoke about being a patient, and I love that. In small conversations at conferences when there's a few urologists just hanging out, I always ask, how many, and these are men over 60, how many of you have had a biopsy? Not too many people raise their hands, or maybe. So, and I always wonder how many urologists have had biopsies, right? And I know a few have, but if I had to guess, based on all the urologists I've asked, it's very few. I don't know, less than 5%.
Mhm.
And I think none of their PSAs are rising. That's impossible, right? So I don't want this rod of my rectum and needles going through, or perineal now, unless I absolutely need it. Unless it's like, look, there's no other way.
Sure,
So we're trying to help people only get biopsies when they need it, because that's the only way. Now, Mark Emberton, I don't know if you're familiar with the study from Germany where they looked at
sure.
on
Yep.
people, those that were not biopsied and versus those that were, and they saw that there was similar results. in
Right.
terms of those that were diagnosed based on imaging. So if they had a positive MRI and a positive PET, that was good enough. So
Hmm.
Mark Emberton from the UK is saying, yeah, I think there's a future. The first time, I think there's a future without biopsy. Whoa, not even I've said that. So, but we probably have a little bit to wait for that. So, what are the things we can do for patients who only do the things we need to do when? Now, you're a surgeon. You've done, I think I heard you say, what, 3,000 operations, if not more. Am I right on?
Between the opens and the laparoscopic and the robotic, probably close to that number of prostates.
Right. That's a significant amount. So, this is your specialty. We want to try to help patients and me with lifestyle things, not to need these aggressive treatments unless they need to. Patient comes in, Dr. Albala, I don't want a biopsy. I had a friend who had an infection from blah, blah, blah. What's your process to try to help them avoid a biopsy if possible?
I think, obviously you get a good history and physical. And, I pay a little attention to the family history if they've had a father or brother that's had prostate cancer, and after getting the history, doing a good exam on the patient. I mean, there still is a role for a digital rectal exam. In the old days when I was a resident, I remember working at a VA and every patient that came in had a rock hard prostate.
Mm.
And PSA testing really over the years has changed that. I mean, it's a good test. It's not specific for, but it also can create anxiety to patients. So if they come in with an elevated PSA, the rectal exam is normal. The one thing they're thinking is, what is the chance of me having cancer, and do I need to get a biopsy? And those are relevant questions. They're important questions. And I kind of look at the individual, and obviously you want to look at their overall health. If they have significant comorbidities and so on and so forth, their age and other factors. But, we do have an array of, tests that we can use to try to answer that question. Is a
Before you go
biopsy?
there, David, what's your opinion on free PSA? How valuable is it? So I've found that it's actually more valuable. So, for example, if a patient has a free PSA percentage of 10 or less, definitely they probably have not only prostate cancer, but significant disease. I think 10 to 20 is kind of murky, and above 20, maybe not so. And then we'll look at other things. What's your opinion on free
I
percent
agree
PSA?
completely. I use free PSA. It's one, I don't hang my hat on it,
Mm-hmm.
but I is looking at the gestalt of the patient, a piece of information. If the PSA is elevated and the total PSA is 25%, you know, there's a more likely than not that patient is probably going to have an enlarged prostate and may not have any cancer. Obviously you can have a high free PSA and still have prostate cancer. So again, not an exact test. A lot of people want things exactly. My PSA, tell me what I need to worry about when my PSA high. We morphed from a PSA of 4 to age specific PSAs, 0 to 2.5 for those 40 to 49 year olds, 50 to 59, 0 to 3.5, 60 to 69, 0 to 4.5, and 70 to 79, 0 to 6.5. So we morphed into age specific PSAs. And again, I use that piece of information. I also look at the PSA velocity and say, we've tracked PSA over a period of time. What does this tell us? Is the PSA always rising? And is that rise, 0.75 nanograms, or in younger men, is it 0.5 or 0.35 nanograms per milliliter per year? What's the magic number? You want to use all of these pieces of information, but there still comes out a number of patients through the chute after they have all of these tests that you're still murky. And those are the patients that, some of them are very anxious and they say, well, do I need to get this? Do I really need to get this biopsy done? And that's where, the biomarkers come in to help us. And I do believe that before I die, we will be diagnosing prostate cancer without a biopsy.
Wow. That's a
I
big statement.
make that prediction here. We've done some work with phenotypic biomarkers, not looking at, but looking at how the genes act in their environment. I think there's great interest and sort of drive forward to find a way to diagnose these conditions in a minimally. And I believe before I die, we will see that come to fruition. So
That's an
I'm a
amazing
little,
statement. You and Mark Emberton, I think alike. I think.
but that's not in 2024.
Yeah.
That's not quite ready for prime time. So we do have an array of different tests that can help us. And the first question is, if I do a test, can it tell me that I don't really need to do a biopsy? And we have some of those tests available. We have tests that are blood tests. We have tests that are urine tests. So you get to a whole array of different fluids, if you will, in the body that we can use to help us, gain more insight into a particular disease to help us diagnose it in a better fashion.
Before you go there, I'm curious, what's the highest PSA you've ever seen where the patient doesn't have prostate cancer? So for me, is 20. How about for you?
Oh, I've seen patients higher than that. I've seen them in the 40s or 50s.
Wow. And then you're thinking, I'm missing it, right?
Then there's one individual I remember doing 4 biopsies on because I couldn't believe that it could be that high.
And this is before MRI technology, probably.
This is before MRI. So the grant 2020, it's a whole different world than in the 1980s and 1990s and 2000s when I was training and then practicing initially. And then I've seen PSAs as 4,000, 5,000 individuals with prostate cancer. So
do you biopsy those guys if they come in, or you just assume they have metastatic disease? And today's discussion is also brought to you by the makers of the ExoDx test. The ExoDx prostate score is a non-invasive, no DRE necessary, so no finger up, no prostate exam necessary, urine test to determine if you need a biopsy. Now, we all know the issues with the PSA test. It is a great test in my clinical opinion, but is imperfect. So what else is out there to determine, what, I really need a biopsy? Unfortunately, there's no other way around it. That test is the ExoDx test. Again, a urine test, pee in a cup, send it to a lab. It gives you a score. If the score is above 15.6, you likely need a biopsy. If it's below 15.6, you may not. So this urine test, the ExoDx test, should be part of the decision-making, part of the shared decision-making between you and your clinician on whether or not you need a biopsy. To learn more about the ExoDx test, please visit the link below in our show notes.
The algorithm's changing. I mean, I like to get tissue. So for me, I don't think you have to do big fusion MRIs. Usually if you exam, their prostates are right. And typically in the old days, we'd just stick a needle in, get a core, you'd have a diagnosis, and then you'd place the guy on ADT therapy. Now we look at PSMA imaging, prostate specific membrane antigen. That's a game changer, man.
Game changer.
I mean, looking at targeted molecular imaging, that is going to drive. And look at now how we treat prostate cancer. I mean, when you and I trained, it was hormonal therapy for this advanced disease. Now there's a whole cadre of drugs, these oral antiandrogen. All of these drugs are changing the way people, and it's beneficial. I mean, if you get prostate cancer today, the odds of you having a longer survival when we train, it's dramatic.
Yeah.
I mean, dramatic.
Yeah.
So,
yeah, I keep saying, no one wants cancer. I don't want cancer, but if you have to have cancer or prostate cancer, this is the best time to have it.
No question, and that's the best cancer to get too, probably.
Yeah.
I can't think of any other disease that it's cancerous that we do active surveillance on. I mean, I just, that's the beauty of urology. I mean, you think of testicular cancer, used to kill so many people. That is probably the greatest success story in medicine. I mean, whether you like Lance Armstrong or not, the guy had testicular cancer to the brain, and look at the guy. I mean, the guy can ride a bicycle, whether with some steroids or not, another debate. But the fact that the guy can perform at that level with that disease is incredible.
Yeah, I completely agree. So what are those biomarkers that are available? So then the PSA says something, free PSA says something else, and we still don't know, and we want to confirm more to know if they need a biopsy. So what are those biomarkers and which ones do you utilize? I just heard, so I came back from ironically, a functional medicine conference. So functional medicine is like holistic medicine that's science-based. It's a thing. And I'm a functional medicine doctor. LabCorp is there. Okay. They've been to those conferences. So the IFM annual international conference is the equivalent to the AUA for functional medicine doctors. So to put things in perspective, LabCorp. And I'm talking to the rep there, and it says, yeah, you know that we have PHI now, Prostate Health Index. Like that's I was like, I did not know that. I didn't know that you could just order a LabCorp test, order PHI through LabCorp. So it was fascinating. They also bought Invitae germline genetic test. So they took over that. And I was very impressed with that. And I've never utilized PHI. So what are the tests that are out there, and what are the tests that you use as a biomarker to try to prevent patients to get a biopsy, or if they need one, then these are the tests that you go by?
Oh, I like to break it into two categories: blood biomarkers and there's urine biomarkers.
That's right.
And the blood biomarkers. You talked about the prostate. Bill Catalona has really popularized that and made that available to a lot of urology practices. It's a relatively simple test, and I think it's a good test. I mean, are validated. They're used around the country. You have the 4K score, which is another blood looking at different isoenzymes of PSA, and if you have a high 4K score, there's a higher likelihood that prostate cancer.
David, do you question these blood tests that use PSA? So this is kallikrein 2, and for the audience, there's different kallikreins. These are different proteins. There's about a few in the prostate, 4 or so. 4K, they use 4 kallikreins in an algorithm to come up with a number. PSA is a kallikrein, and I believe it's kallikrein 2, I want to say. What do you think of the fact that they use kallikrein 2 or PSA in part of their algorithm? So I've seen a lot of false positive in men with big prostates who have a high PSA, and what role does that? Obviously, this is proprietary information, so we don't know what those algorithms are. But I always question, what role does that number make in the calculation, the algorithm to come up with their number? Because I've seen a lot of false positives.
Yeah, and I think that's a valid criticism. I mean, obviously, the secret of the test, if you how much do you weigh the kallikreins in that equation to get you that 4K score? But I think that when you look at how it's performed in groups of patients, every test, there's no perfect test, but I think this test, the 4K score in particular, performs pretty well. I mean, it's clearly
it's better than just PSA.
It's better than PSA. Now is it the best? One can debate that. And without all the information, it's hard to make a really true assessment because you can't, just say, well, they're weighing one more than the other and so on and so forth. So, but I know there are a lot of urologists that use 4K. It's easy for patients to understand it. They're looking at this PSA, molecule. So, I mean, I've used it. I've used all the biomarkers, and I think they all have strengths and weaknesses. And what you have to do is decide for you what's the most important thing. And to me, when I look at a new test, I look at sort of 5 things: whether it's a drug, whether it's a procedure. I look at the efficacy. I look at the cost. That's important, I think, in the equation. I look at the side effect profile. In other words, if I'm giving a particular drug or a treatment, what's the risk for the patient? I also look at the ease of doing that, whatever it is, blood test, procedure. And then I look at durability. And so those are the 5 markers. Whenever I see a new test or a new procedure, those 5 things kind of hit my head. I was blessed to lead the FDA trial on microwave therapy for low energy. And the microwave story is a great story, for treating BPH. It was a minimally invasive treatment. It came out, at least in the short term, it looked really good. The patients got good results. It was easy to do. The risk for patients was, with low energy microwave, was really minimal. The cost was reasonable, but where it fell short was durability. when you followed it along the line, those patients that got treated fell off the 5-7 years down the road.
Not to
So
completely digress, David, but are you not amazed with all the treatment options for BPH these days?
I'm blown away.
When does it stop?
It's, we've just started, I'll tell you, we've just started doing prostate embolization.
Yeah, yeah,
And
PAE.
PAE, and I've written 12 books. I wrote a book on BPH.
Yeah.
And, then all of a sudden PAE, we had, the microwave, we had green light, tulips. I mean, I go way back. Now Urolifts, resumes.
Back in the
Now
day, it was TERP, and that's it, right?
it is. I mean, I remember one of the nurses saying, when I finished my residence, said, how did I do as a resident? She looked at me and she goes, I got to tell you, you do a great TERP. And I loved doing that operation. That was a great operation. I felt like, you debulking the tumor. I mean, the prostate, opening up that passage. Good recipients are hard to find today. The older urologists, which I am part of that group, with all those options, I mean, I don't know how patients make decisions. And that BPH pathway is so complicated today.
Yeah, that's one of the hats I wear. Where for either BPH, and then my audience knows that I don't do any of these treatments, but I'm familiar with them, and they'll say, "Look, help me out here. This is what I have.
Right.
What do you think?" And I've had a few experts on HOLEP and aqua ablation and so forth.
I mean, that's aqua ablation, PAEs. Robots are coming in everywhere. So it's and we saw it with prostate cancer. When I trained, we did an open prostatectomy. Some of us were blessed to learn how to do perineal prostatectomy. I did those in Chicago.
Those were the few forms. That was in the beginning, back with Hampton is his name.
Hugh Hampton Young.
They were all perineal prostatectomies for a while, right?
No, and then when I got to do, David Paulson is probably one of the greatest perineal prostatectomists in the country, and
from Vanderbilt.
But
David Paulson. Oh yes, sorry, gotcha.
Yeah, he was at Duke. He was the chairman at Duke, and when I got down there, he calls me up and says, I'm seeing a patient in the clinic. He needs a prostatectomy. Do you know how to do a perineal? And I said, oh yes, Dr. Paulson, I'm ready. Well, I'm going to come watch you. And I was like, oh God, here's the guru. Come watch, the young guy. I go home that night. I read think about this whole thing. I go in the OR and I'm looking around for Paulson, and I start the surgery, and I don't know when he's coming in case. And, I look around and about an hour later, he calls me, oh, I got held up and I couldn't make it, but I know you did it, but, and then I went over to Paris and, from the French, learned how to do laparoscopic prostate, and a game changer in some respects. That hard up, you had to be really good. And, people in, Guilleneau and a number of really great Claude Abou and a great number of laparoscopic prostatectomists. And then, when robotics came, we were very much an early adopter on robotics at Duke. I mean, they had a robot, the cardiac surgeons were doing it. My fellow and I were walking by, and it was kind of in the hall collecting dust. And he looks at me and he says, those guys in Detroit are doing it robotic. We need it. So we flew up to Detroit, Manny Menon. At that time, Vip Patel was just starting the program in Birmingham, and we went down. And when I saw Vip Patel for the first time, it's like I know what it's to be a baseball scout. When you see somebody that's got this talent that's incredible. Vip is a very good friend of mine, and he's done
10,000.
10,000 prostates. Yeah. It's incredible.
So for the audience a little bit, because this is like having coffee and people are eavesdropping. People are saying, who are all these people? What? Perineal? What? So perineal operations is the area between your scrotum and your anus where they used to remove the prostate in that fashion, as opposed to around the belly, between your pubic bone and your belly button, which is...
It was primarily reserved for really obese patients.
Yeah.
It was really nice in the old days when you were doing a prostatectomy through a midline and near the umbilicus, you'd have to go down through all the fat layers, if you will, to get to the prostate and the pelvis, and it was a long way down. The perineals, you can imagine if a patient's up in stirrups and you make a U incision, above the rectum, it's kind of a direct line right into the prostate. But you had to be careful, because if you too low, you're going to get into the rectum.
Yeah.
You couldn't do a node dissection. So there were, little tricks of the trade, and that kind of fell out of favor. And then, we morphed into laparoscopic and robotic prostatectomies.
So we'll talk about treatment in a second, so you can get deeply in a little bit there. We digress quite a bit. We'll come back
we
to
talk about to the markers.
Yeah,
let's go back to the markers, because that's an important thing.
Yeah, exactly. How can we prevent and avoid these kinds of treatments that are honestly, not to continue the digression, and I'm not a surgeon, unbelievable. These people, I mean, you guys are so skilled. I'm in awe when I see a patient before they get treated, see them after, and once they get their catheter removed, 99%. Now, I am in a homogenous world, and great surgeon, NYU.
Sure.
Even if they go see our colleagues at Sloan, James Easton, or whoever else, I mean, it is homogenous. Many patients that go see Vid Patel. So that's that. I know not all patients get results. You go to these forums and they're unhappy. But by and large, the patients I see get amazing results.
No question.
It's remarkable.
Going back to the markers, so we
talked about the blood markers, prostate health index, and we talked about 4K score. Tell me a little bit before you go into urine, David. Health index. You've used it. I never have. I've seen some results from patients who have had it done from others. Same scenario. They use PSA in their algorithm as well. Today's discussion is brought to you by yet another amazing sponsor, Veracyte, the provider of the Decipher Prostate Genomic Classifier. Here's the deal, folks. After a prostate cancer diagnosis, what you want to know is, how is my cancer different than any other? The Decipher test helps personalize the diagnosis a little bit better so that one knows how aggressive their cancer is, because we all know that not every prostate cancer is created equal. I clinically use the Decipher test almost every day, as it helps me determine, how is this particular patient in my office, prostate cancer, different than the guy I saw earlier today, or different than the guy I saw last week? How is their particular tumor behaving differently or will behave differently? That approach helps with the shared decision-making between you and your clinician as to what's next for me. What is the best approach? To learn more about the Decipher test, please visit the link below in our show notes.
Right. They use multiple factors in that algorithm. Again, it's a proprietary algorithm.
Yeah.
And, I have not used it. It's interesting. Politics are local, and there's certain beds, around the country, that think that test is great, and they have it available in their laboratory services. When I was at Loyola, we didn't have, we did a couple tests because of the influence of Bill Kettle, in Chicago, but at Duke, we didn't use prostate health index. So of all the markers, it's the one I have probably the least experience with. But I've read many of the papers, and, it seems to be a pretty good test. People swear by it, like it. It's easy to do. And it provides, one more piece of information in the puzzle, if you will.
And now available through LabCorp. I think that's relatively new.
That's really incredible. I didn't know that either.
I just learned that at a recent conference, functional medicine conference I went to. Available at LabCorp, so it's probably easier. All right, continue. Sorry.
So, and then I think in the last few years, we've started to see a progression out of blood markers, biomarkers, to urine biomarkers. Urine is a little nicer because everybody urinates for the most part.
Right.
It's easy. The specimens, you don't have to stick a needle in anybody. So there are a couple caveats between the different urine biomarkers. There's two urine biomarkers that are out there: the Select MDX and the Exosome DX test. And, both I think are good biomarkers. They provide useful information. They're slightly different. Select MDX, you have to do a digital rectal examination. And with the ExoDx, you don't need to do a digital. So, I Select came, so I jumped on the bandwagon, was doing many of those tests. And, again, similar to PCA3, which was another urine biomarker that we had, you had to do a digital rectal exam. And a clinician, massaging the prostate 3 times on the right and 3 times on the left, and who knows how much pressure you really need to put in. But when Exo came, that was a game changer for reasons. One is, it was a very novel. Exosomes are really kind of a novel biomarker. It looks at, it's a genomic marker. It looks at tiny extravesical particles that are released in bodily fluids. So you have exosomes in blood, you have it in semen, you have it in urine, you have it in cerebral spinal fluid. And what these exosomes are, they're packets of RNA, DNA, and protein. And they really are a means of cellular communication. So they can relate and tell cells you got to grow faster. They're really in the communications network. I kind of like to think of them as little, that
Little
you get a little
tweets.
piece of information. It's a tweet piece of information. But what the beauty when exosomes came out, then COVID hit. And COVID kind of changed the way we practice. I mean, there's just no two ways about it. Patients weren't coming into the office.
No rectal, no prostate exam.
So no prostate exam. So Exosome was very smart because instead of having a patient come in and leave a urine specimen, they could mail the kit to your home.
Yeah.
And we participate in the Telehealth with academic institutions, around the and what we showed is that patients can do this at home. Wake up in the morning, pee into this special collection device, call the FedEx guy, and you can get the results in a couple of days.
Amazing.
And then I could do a televisit. So I could have a patient with an elevated PSA, do a televisit. So granted, I wasn't doing a rectal exam. I haven't perfected the rectal exam through the computer.
Not yet.
But, that day may happen, but
right.
The exosome test, you could have a patient do at home, and then you would have even a more significant piece of information, than PSA. And that's when a patient comes into my office now, my thinking is if they have an elevated PSA, and I've used free to total PSA, I've used age-specific total PSA, I like to do an exosome test first. In my working of the algorithm, if the PSA is between 2 and 10 and you're over 50 years old, then I tend to get an home test. And I have to their home. I don't have them collected because when they come into the urology clinic, they're always leaving a urine specimen because I look at every urine in every patient. And I don't have to have them hang around, provide me with another urine specimen. So the ease is really nice.
Yeah, that's what I do as well. I do telehealth visits with people. I have the luxury of doing it with people from all over the country, and it's just so easy. You just easy portal, and they get it, and you get the results within a week or two. Very easy.
It's really quite simple, and and then.
Do you ever use? Sorry, David. I'm just thinking. Do you ever use ExoDx and then a blood test like a 5 or a 4K to confirm that, or do you ever do that?
I haven't
or you
done
just go...
that. The validation studies. There have been validation studies, Journal of Clinical Oncology, and EAU. The EAU journal in Urology journal. The test is really pretty. You get a score that ranges from 0 to 100. The higher the risk of high-grade prostate cancer. And it actually correlates with a 1-to-1 relationship up to about an EXO score of 50 to 55. So if a patient comes in, elevated PSA, you do an exosome test, the EPI test, and that score comes back at 40. They have about a 40% chance of a high-grade cancer. It's 1-for-1 up to about 50 to 55, and then it plateaus off. So the first thing that's important is, the cutoff is 15.6. That's where all the validation studies. If you have an exosome score below 15.6, likely of a high-grade cancer that's going to really hurt you or kill you is almost zero. Nothing in life is zero except for taxes, I guess, and death.
Right.
But no, if that exosome score is below 15.6, you can rest assured that the likelihood of you having a high-grade cancer is extremely low. So that's the first thing. So if it comes back with a score below 15.6, I feel pretty comfortable saying to a patient, I don't think we need to do anything further. I think we can.
No MRI?
I don't do it if the exo score is below 15.6. Now,
where do you go? So how far out do you go before you say yes or no? Is that a strong, stop if it's 15.6 or higher? Do
You
you go
know,
when it's 17, 18?
that's where the art of medicine comes into play.
Right, right.
So you need to look at the patient. If he's an anxious person, he's got a family history of prostate cancer, his brother died of prostate cancer, I'll probably tend to be on the more conservative side and probably would get the MRI.
Hmm.
If the patient has a markedly enlarged prostate, it's 60, 70, 80 grams, and that exo score is, 15, 16, 17, then I might say we can do this, but I'm also comfortable watching you for the time being and seeing what happens and follow that PSA.
Hmm.
So, and then obviously if the exo score is above 20, pretty much it's a full stop for me. I say we need to get an MRI.
Hmm.
And that's where the beauty of this test in conjunction with the MRI, helps us determine prostate cancer. So
Yeah,
it's interesting. And they did a clinical utility study with the EXO test and asking physicians and patients. The physician makes a recommendation.
yeah.
And you have an EXO test that below 15.6 and your physician recommends this to you. What's the likelihood you'll follow through? And these numbers are, if you have a high test, 92% of going through with a biopsy. If you have a low test, 72%. And when you look overall, by doing the EXO test, you actually detect about 30% more high grade than you would have. So there clearly is some good scientific literature out there supporting the use of this urine test. And it's so easy to do. It kind of fits the Albala five-star category. It's easy. It's efficacious.
Yeah.
There's low risk to the patient. The cost is reasonable. And the durability, at least what we've seen now, is really quite good. So to me, that fits the gold star kind of test.
How often will you repeat it in a patient that has a low ExoDx score? Do you use it similar to PSA every 6 months, every year, or does it
Typically not.
depend?
Typically not. If the EXO score is well below 15.6, and I've seen really low ones, I would tell you if it's, 13 or below, I never, ever repeat it. I just follow the PSA over a period of time.
And unless
Now,
something changes in their PSA that's pretty dramatic, then you'll order another Exo.
exactly. Yep. Or if I feel, obviously if I feel a nodule that, on a physical exam, we can't exclude, of doing an exam, obviously, because if you feel something, one of my partners, a senior partner, more older than him, I patient came in, I felt a kind of an induration in the prostate, and his PSA was normal, and this is actually before the EXO test. I set him up for a biopsy, and my partner did the biopsy. He said I wouldn't have done the biopsy on the guy. Did the biopsy, came back with a Gleason 7 tumor, and he came to me and he said, I got to tell you something. I didn't feel anything you did, but whatever you felt, exactly where you felt. Now, our fingers are not really good at picking up prostate cancer. Right. I think there was a study with some academic faculty looking at, I think it was out west, if I'm not mistaken. And they had the faculty do rectal exams, and 50% of the time they were wrong.
Yeah.
Now, as a urologist, I was trying to think, I wonder how many prostate exams I've done in my career. It's got to be 30 or 40. I mean,
yeah, exactly.
Got to be some incredible number.
If, even if there's a steep learning curve, you've passed that learning curve.
Yeah, I think so. I think so.
Ago.
And I think important point when, for your audience, when you get a physical exam, a rectal exam is part of that. And I think a lot of primary care docs don't do that anymore.
So you're gonna enjoy this. I have an audience, a newsletter audience, about 10,000 subscribers at drgeo.com. And I wrote a provocative piece. I said the end of the DRE, right? So why? I think I highlighted that study that you mentioned.
Mm-hmm.
It was, during over a year, it was a year over that we have not performed a DRE. I didn't see rates of prostate cancer go up any higher than comfortable, this and that. And so the conclusion that I made, and it was, well, maybe we don't, and I see a lot of telehealth patients. Most of them see a urologist and get a DRE. So I haven't done a DRE in a while myself because I see so many telehealth patients now.
Sure.
And I wrote that piece, and a few people said, "Oh, great, it's uncomfortable anyway." A few urologists who are on my subscription list said, "Are you crazy? Are you nuts? Of course you need to. It's still very valuable. This is poor blogging or writing and so forth." So there was a little bit of a
Well,
difference.
there's no question it's controversial. It's the same controversy when we did robotic prostatectomy.
Yeah, I remember that.
All the open prostatectomies would say, "Oh, you can't feel anything," but
Well, my boss, Dr. Lepore, was very much in favor of robotic prostatectomy back then. I'm being facetious, of course.
I debated Dr. Lepore.
Yeah.
We would, he would argue, "Well, Bella, we can feel the prostate nodules," and I'm like, "Well, as a robotic surgeon, I can see the prostate nodule, so I can see. I don't have to feel."
Yeah.
And your eyes become your hands. And that was my argument. I'm not sure who won that debate. I kid Herb to say that I won the debate, but obviously I've won it because look at the number of prostatectomies being done today. 90% of them are done robotically.
Even more than that, probably. I think, look, it was Scardino, but he retired. He used to do open. There is one surgeon somewhere recently that I learned that is doing open, other than
Well,
Herb
Judd
Lepore.
Mao, my former boss at Duke,
Judd is still doing open.
still does open prostatectomies. And listen, the guy is a great prostate surgeon.
Well, the thing is this, and once again, I'll repeat, I'm not a surgeon. I've been around you guys for a long time, and so the way I see it is, if you're a good open surgeon and you've done so many, there is no difference. But the question is, how steep is the learning curve to be as good as a Herb Lepore or Judd Mall?
Right.
Bill Catalone, I want to say too. I don't know if he's doing it.
Right? He's not on, but you're exactly right. There was a steep learning curve, but there was a steep learning curve in robotics too.
Mm-hmm.
I mean, I think back, my first robotic prostatectomy I did at Duke was a guy that worked for the university, and he heard that we were doing robotics, and he came to me and said, "I want to be the first because I believe in new technology." And that case took me 8.5 hours. And I got out of that case, and I was scratching my head, and I'm like, "Oh my God,
I can't do more. 3 of these cases. There's no sleep.
And then now, it's an hour and a half to 2 hours to do a prostatectomy, and I look and you see it's kind of like going to a batting cage. If you go to a batting cage 6 hours a day, I'm a big Red Sox fan. So
my condolences.
I would say you can play for the Yankees, but not the Red Sox.
Well, I think this podcast interview has ended now that and live in New York too. Wow. Are you from New England?
I am. My dad was actually a hematologist at Brown. I went to med school there, and I have great memories of Providence. And my dad, when I was a kid, took me up to Fenway, and it just was a great experience. And
father-son moments, right?
And I'm home from medical school, and I said, I'm thinking about going into hematology oncology. And he kind of looked at me and he said, "Dave, you have to be really smart to be a hematologist." I said, "Okay, I'm going to go into urology." And then 20 years later, when he's retired, and when I was a tenured professor at Duke, I was sitting on the porch one night, and he's passed away, but he looked at me and goes, "The things you've done in your career are just unbelievable. I mean, you've traveled. I've operated in 42 countries, doing laparoscopic nephrectomy. I was blessed to be with Ralph Klayman when we did the first laparoscopic nephrectomy, and gone all over the world operating, and writing papers and writing books, and and my dad just looked at me and he goes, "I never would have imagined that you could have done what you've done." And it was one of those father-son moments that my dad was really driven, and but he was if he was uncomfortable in certain things, like I remember him taking let fellows do bone marrow biopsies on himself, because they didn't have anybody to practice on.
Right.
But
did your dad get to see the Red Sox win a World Series?
He did not.
Ah,
he did not.
As much as I hate the fact that they did win a couple of World Series, I would have loved, hearing the story for your dad to have seen.
But I think he almost had a stroke when the ground ball went.
Bill Buckner.
Bill Buckner's legs. I thought
86 when the New York Mets won.
Exactly. Painful for us Boston fans. But what's really blessing about our careers is, we see this change, and we see the good that we do for people. And that's, I get up every morning and, sometimes it's tough going to work because it's hard, but, you think, I come back and I think about I saw a prostatectomy guy I did the other day, yesterday in clinic, and the guy is competent, he's got continent, he's got erections, and he like, I can't thank you enough. That is the reward. And, we're
It
so blessed
is.
to be in, and
Absolutely.
with the technology changing, and these are anxious moments for people. And, as a physician, you really are guiding the ship and you're providing the information. And that's why you want to get as much information as you can.
Yeah, absolutely. David, Exo, let's go back to Exo for a second. I have a question. So, what's your opinion? I've used Exo a little bit off label. I think there's a study on it with what I'm about to say, but not published yet. Gyroactive surveillance. Good indicator, maybe? Because, I mean, look, you need a I understand you need a confirmed biopsy after that initial one eventually. But after that, I mean, what are you going to get a prostatectomy by default by doing all these biopsies? So I want a tool to help me decide if my patient needs more biopsies or not. And I'm thinking, again, I'm just kind of experimenting. I tell my patients, look, this is off label. You've already been diagnosed, but I'm
Sure.
getting your baseline when you get that first biopsy, and we'll see later on what that looks like, if to give us some information along with PSA whether you need another one or not. What's your
You
thinking on
know,
that?
it makes total sense to me,
Mm.
but, and I think this will be validated, quite honestly, in my crystal ball and making a prediction.
Mhm,
I
mhm,
think some future with exo in the active population. And as you said, that study's being done, and I think we'll have that data. My gut feeling tells me that makes a whole lot of sense.
mhm,
And you're right. I saw a patient just the other day that was on active surveillance. He got one biopsy. He developed, C. diff after the antibiotics, and
mm.
had a kind of a and prostate. And for 10 years, the guy has refused to get a confirmatory biopsy after
Not
that
doing it.
first biopsy.
Not doing it.
And
Right.
every time I come in, I dictate in my note, patients refuse to have this. And he came in this past week, and, he's with him. And he said, his PSA kind of hovered up and down a little bit, but really didn't change. And I said, I got to tell you something. You have kind of shown me something that I was pretty narrow minded on.
Mm,
And, that obviously, you know, that's not what I recommended to you, but
mm.
and maybe you don't need to do all these confirmatory biopsies in these people. And we do need a test to help us with that.
Yeah.
And I think this is the one, quite
Yeah.
honestly.
And AI and so forth moving
Oh
forward
yeah,
will play a
no
role.
question. Yep.
Hey, have you seen in a situation where let's say you have a discordance between the MRI and the exo test, right? So let's say the exo test is 20 and the Pyrette score is 2. In my mind, because there is so much subjectivity still with MRI and the radiologist, number one. Number two, I don't know who I trust. What radio are they seeing? Only prostate MRIs all day? Or are they right? So I'm thinking I'm going to go with this exo, and I'm going to look further because the exo test is 21. Our next amazing sponsor is XY Wellness, a company I know a little bit about as co founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program and what we see with many of our members is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show notes.
I clearly,
Yeah.
I'm with you. I think the blood test, there is this interoperative variability that exists. And so I would that and I have these patients, and I have biopsied them, and I have picked up cancer. So again, nothing is 100%. MRIs, the PIRAD system, one through what Gio was talking about is, as the PIRADS gets higher, the risk of finding a cancer is higher. So a PIRADS 5 is going to have a much higher risk than finding a cancer in a PIRADS 2 or 3. So, but that's why I think the blood test and urine test markers are going to be a little bit better, because there's it's consistent across the reader availability. What Dr. Geo sees and Dr. Albala sees could be two different things. That's related with the urine markers or the blood markers.
I did have the radiologist Margolis, Daniel Margolis I had him on. It's going to be published soon. What a gem. And he mentioned that they are having certification for prostate MRI radiologists specifically by their institution, their organization, on reading prostate MRI specifically. So and that's going to be, I think, a game changer, because that's my issue with my only, again, I'm at NYU. Andrew Rosenkreutz has written the books.
Sure.
So this is homogenous. I get second readings. This is crazy that I'm even where
there's a great meeting that's held every year in Boston called the ADMETech, ADMETECH. I think it's in October of this year.
ADMETech, yeah.
And it was started really by a radiologist to talk about prostate cancer. She had a friend that died of prostate cancer. It's been this whole evolution for prostate cancer, and her name is Faye Stern. Is the person. You can look up ADMETech, ADMETECH, and it's open, to clinicians. It's a virtual meeting. It used to be in person. COVID hit. It's been virtual for the last couple of years. The lectures are off the charts.
Good.
It's the top.
To look into that.
It's the top prostate cancer people in the whole country, in the whole world, and especially with regards to, they've talked about changing the PIRAD system and how to make it better, and treatments and so on and so forth. And it's a great. I would encourage, if physicians are listening, and it may be open to us too. I'm not sure about that.
Well, I'm definitely going to look into that, and thank you for mentioning it.
It's a great people from Memorial. I know, Sigrid Carlson, who's an epidemiologist, has lectured there, and Jim Eastman's, been there. I mean, it's a who of prostate cancer gurus around the country.
Excellent. Lastly, you talked about laparoscopic surgery and robotic. I think a lot of people interchange the two. What's laparoscopic surgery? What does that look like? Is it still performed, and for what? And I think most people would know what robotic is at this point.
Sure. So, I was blessed. When I finished my training, I went to St. Louis to do my fellowship. I worked under a guy named Ralph Klayman.
WashU.
At WashU, great hospital. And Ralph Klayman is, I got
Mount Rushmore, maybe.
Yeah, more than Mount Rushmore. Denali, quite, that kind of level. And they were, at that time, general surgeons were taking gallbladders out laparoscopically. And essentially a laparoscopic procedure is you fill the belly up with carbon dioxide gas, you put in these cylindrical tubes that you can pass instruments, and you have a camera, and you're working on a screen, and you're standing at the bedside manipulating these instruments to take the gallbladder out.
So as opposed to robotic, you're standing 12 feet away, maybe?
Yeah, you dock to those trocars, and then the surgeon sits at a console, in the corner of the room, or even in Vip Patel's case, he's in a different room. He's in a totally different room.
Yeah.
And you have someone at the bed.
Hey, what stops us? My brain just goes on fire when I'm listening to people like you. What stops us from doing a surgery? If we can do it a room away, can we do it a block away? Can we do it a country away?
We've done it.
Yeah.
So the first telesurgery was actually a French surgeon who was operating in New York, took out gallbladder in France. So that was the first telesurgery. Jacques Marc was the general surgeon that did that. Then you started telesurgery being done in Canada. Canada, a huge, vast country, rare to get skilled laparoscopic surgeons into the rural areas. What you could do is have a robot that you could dock, and the surgeon could be in Montreal, and you could be doing surgery in Saskatchewan, in the boondocks of Canada.
Yeah.
So that changed all of a sudden in the last year. So Vip Patel went to, again, a lot of this is an evolution. And I've actually just written a piece, for the International Urology on telesurgery. So as we've seen this evolution in robotics take place, we had one robotic system, the Da Vinci. Now there's 40 robotic platforms. In China, they've got, almost 20 different robotic platforms. And so what we've seen is this evolution take place of robotic systems. And what's really critical is the safety of the patient. That's the overlying thing that's going to drive telesurgery. You have to do the procedures safely and have the ability to do it safely. And we've been able to do that, quite honestly. Wow. That's what's, and he went to China and he operated in 4 different provinces in China, sitting in Beijing, and was able to take prostates out in China. Really incredible. So,
incredible.
Really, really incredible.
So laparoscopic surgery, you were talking before we digress into robotic surgery.
So laparoscopic surgery is where you fill the belly up with carbon dioxide gas and you stand at the bedside and you manipulate the instruments to take the organ out. So I was blessed, and we practiced in St. Louis, and we actually did the first laparoscopic nephrectomy in a human. And we perfected it. We spent...
Was Jamie Landman a resident even, or...
resident? This was before Dr. Landman actually probably was in St. Louis. This was when Luke Cavusi was in New York. Myself, PJ Chandhoke, we were the, Sherb Finginshaw, who's a faculty member at WashU. We were there for the first laparoscopic nephrectomy. And that was groundbreaking. The solid organ, not just an organ that has fluid in it, but a solid organ, actually manipulated, carve, put it in a bag, chop it up, take and we did it for benign disease to begin with, but then that kind of set the stage, and now we could do malignancy. So it really kind of changed the playing field, if you will. So I think, and then robotics has been an outgrowth of that. That's just, being able to do it remotely and sitting in the corner of a room really changed it, because to develop laparoscopic skills was really difficult. Robotic surgery, kind of the platform, allowed the common day urologist to learn how to do these techniques without the skill level that the laparoscopic surgeons have.
Are they able to do it like at home, similar to a video game, and kind of learn virtually?
Exactly.
Yeah,
exactly. And that's how the training. We're using simulators and using that to try to learn how to take the prostate out or the kidney out. So our younger surgeons can train on models. I trained on animals. But now we don't even have to use animals. We have, developments of simulation screens that are almost like what it is in the human body. We can create bleeding. We can create the same types of complications and so on and so forth, much like what a pilot does when he goes into an aircraft simulator. He can learn how to land the plane. If he doesn't land properly, what happens, or if something, we can do all those same types of scenarios. And I was in Ireland. They have a simulation lab that's incredible. Really? That it's just like, somebody pushes a button and they got bleeding here. Or it's incredible. It's the graphics is just unbelievable.
Beautiful. David, thank you so much. It's so insightful, particularly as to, how you use these biomarkers to diagnose, or even before biopsies, to diagnose prostate cancer was really insightful. And I'm taking so much from it, and giving us kind of a run through of, some of the history of robotic surgery. I don't know if you know, I will have Manny Menon on.
That will be a podcast to definitely listen to, because
I tell you, I say this. I mean, I can't believe I have this platform, and people like Manny Menon will say, Peter Carroll as well. Yeah, sure, Gio, I'll be on.
Well, the story on Manny Menon is, I met Manny Menon when I was a resident at Dartmouth. He was the chairman at UMass, and Manny Menon was a stone guy to begin with. His was initially built up in stone disease, and he kind of morphed into this robotic surgeon, kind of in some ways like me. Obviously, he's at a different level. He was the pioneer, and just to have the foresight, the vision to changed things, and he's morphed into this incredible robotic surgeon that's really changed the way we practice. And he's a giant. Ralph is Clayman's a giant. I mean, to have people like that on your podcast and to learn from those people is just an incredible opportunity. And
I appreciate it. Thank you, David. Thank you so much. Two things. How can people find you, and final words from you?
I'll give you my email. It's dalbala, AALA, at ampofny.com, Associated Medical Professionals of New York.com. I'm in Syracuse, New York. You can call me. I get a phone number. I'm like, I'm probably an unusual doctor in that respect. People don't abuse it. If you're,
they don't abuse it.
They really don't. And, send me an email. I'll send you my phone number. I'm happy to talk to anybody. I've just loved what I've done for, 33 years, 34 years. I've been blessed. I'm proud of, when I was in Chicago, I set up a prostate screening program in Cabrini Green and the homes. It's been incredible. I was lucky enough to become a White House fellow, and, I worked in the White House for a year doing health policy. That was an incredible opportunity. But I have a kind of a moral compass to give things back to the community. My parents gave me a great education, and I've been blessed. I've had a terrific life, and I know not everybody's had that kind of life I've had. And, I started screening cancer in Robert Taylor Homes in Cabrini Green. And, that meant more to me than, operating on some famous doing things. And, I think that, as physicians, we like to give things back, and I want to be remembered for giving things back to my community. And also urology is great.
Wonderful profession.
I wish I was starting a residency again, because a 50-year, it's not, I'm blessed, and I'm just grateful for all those people that have taught me. And, I've had great mentors. I'm just a lucky guy. I'd like to help people. And that's, I got my degree in geology. I wanted to go to forestry school, and, I went to a small college in Pennsylvania, and, the geologists, I got into grad school at Harvard and Stanford, and I really wanted to go to the Yale School of Forestry, which I got into. And when I told my professors I was going to go into medicine, they were like, "Oh my God." And then it turns out that 4 of my professors, 3 of them had prostate cancer, 1 had bladder cancer. I did on all 4 of them.
Oh, wow.
I just went back to my college, and, I had breakfast with the 3 guys that are alive. And they all looked at me and they said, "We are so glad you didn't go into geology, and so glad you became a urologist."
And so is your father. Sure.
And my dad is proud. My dad is proud. Hematology, I'm sort of doing a little bit of it, oncology, but
right.
I made the right choice.
David, thank you so much. Thank you for your time, knowledge, expertise, and passion, and to share that with me and my audience. I really appreciate you.
Gio, thanks for having me, and I'd love to come on again sometime and, talk about something. You're doing a great thing. And again, thank you for the kind invitation.
My pleasure. Thank you, everyone, for listening to today's podcast. Look, how do you avoid a biopsy? If you can. This is, Dr. Albala laid it all out. I hope it's helpful. I know it's helpful for you. Please spread the word. Tell your friends, tell your support groups about this podcast. There's no one like it, just because this is what I do every day in and day out. And this is my passion and my mission to help you make better informed decisions and empower you, the self-health advocate, to be a part of the decision-making and be in the driver's seat, if you will. Much love, and I'll talk to you next time. Dr. Gio signing off. Tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com.